Okay, so we're going to be talking about OB trauma and critical care in the next couple of slides, and that will conclude our morning session for today. So again, I'm a maternal fetal medicine specialist. My name is Jamil Alfara, and I'm one of Osler's OBGYN faculty. Again, anything that is included in this lecture was, what do you call it, is a result is consistent with ACOG and SMFM guidelines. So when we talk about traumatic injuries, they're the leading cause of death in young women. And up to 20% of pregnant women suffer some kind of physical trauma or some, of some sort, right? And deaths as a result of injury is the leading non-obstetrical cause of maternal mortality. So blunt trauma, okay? You've got to always keep in mind that there is a chance of physical abuse and intimate partner violence. So 1 to 20% during pregnancy, and it is definitely more likely in the setting of poverty, poor education, somebody who's addicted to alcohol, tobacco, and drugs. Now, the thing that of course is concerning or disturbing is abused women usually remain with their abusers. So even though they're being abused, they're in an abusive relationship, they usually do not leave. Prior domestic violence is a major risk factor that also can lead to intimate partner homicide, right? Incidence is higher in patients seeking pregnancy termination. So as a healthcare provider, obstetrician, you definitely have to be on the lookout. You've always got to be screening. You've always got to be asking. You've always got to make the patient feel that she's in a safe environment to share with you those horrific stories or concerns. Now, usually a lot of times they may present late or not at all for prenatal care. The trauma that they can incur could cause uterine rupture, preterm delivery, perinatal death, placental abruption, low birth weight, and in general, adverse pregnancy outcomes in general. All right. Now, universal screening for intimate partner violence should be performed at the initial prenatal visit, every trimester, and during the postpartum checkup. Sexual assault, it affects about 20% of adult women at some point during their lifetime. And there is a lot of concern with sexual assault, whether it's from a physical, physiological, or even from a well-being standpoint, because patients that are sexually assaulted can get pregnant. They can also incur diseases like chlamydia, gonorrhea, HIV. So even though the psychological and the physical aspect is important, you cannot neglect the need for them to get immediate contraception and get screening and treatment for potential STDs and HIV and so forth. So concern for exposure to STD, you've got to give the appropriate antimicrobial therapy. And remember, up to 35% lifetime risk for each of the following. Psychologically, they may go into post-traumatic stress disorder, major depression, and ultimately, unfortunately, they may contemplate or commit suicide. So the American College of Obstetricians and Gynecologists recommends the following in the evaluation of sexual assault victims. You've got to obtain an informed consent. You've got to assess and treat physical injuries, obtain her past gynecological history, perform a physical exam, including pelvic examination with the appropriate chaperone, obtain appropriate specimens and serological tests for STD testing, provide appropriate infectious disease prophylaxis as indicated, and depending on the patient's HIV status, whether it's known, unknown, you evaluate the risks and benefits of post-exposure HIV prophylaxis. You've got to provide them and arrange for them to get emergency contraception as indicated. And then you've got to provide counseling regarding findings, recommendations, and prognosis. And you have to make sure, absolutely necessary, that you follow up the appropriate you take care of their the psychosocial needs appropriately. You've got to make sure that they see counselors, psychiatrists, OBGYNs quickly in a timely fashion. You've got to always make sure that you make the patients feel that you're always readily available for them should a need for you arise. Okay. Now, legal issues, you've got to help in things that may actually bring the assailant to justice. So you've got to provide accurate recording of the events, document injuries, collect samples as indicated by local protocol and regulations, which may include hair samples, semen analysis, all these things. Identify the presence or absence of sperm in the vaginal fluids and in the appropriate slides, report to authorities as required, and then you've got to ensure that you follow the chain of evidence. And a lot of the hospitals, they do have a protocol for that. They may have nurses that are designated to doing that, but in general, a police officer comes, he has a collection or she has a collection kit, you go into a room with the appropriate chaperone, you do all of your collections, you put them in a bag, you seal the bag, and you give it to the police officer. And if you do not follow the chain and how this is supposed to be done, you may actually end up not being able to use this evidence in court. So please make sure if you are involved in any of those that you coordinate with the hospital and the police officers that are coming to investigate to make sure that you don't do anything to hamper their ability to investigate. So each year in the United States, 3% of women are involved in automobile accidents, and it is the most common cause of serious or fatal blunt trauma during pregnancy, and it is the leading cause of traumatic deaths. Now, many deaths can be prevented by the 3-point restraint of a seatbelt, as opposed to not having a seatbelt, which increases the risk of injury, mortality, and morbidity dramatically. So if you look at the proper way to put a seatbelt, okay, the upper belt is above the uterus and the lower belt fits across the upper thighs and below the uterus. The last thing you want is to have a belt on the uterus, because that, unfortunately, in a car accident may actually compress the uterus, cause more damage than benefit. So when you want the green side, you want the upper part of the belt to be above the uterus, and you want the lower part of the belt to be below the uterus, so the impact does not hit the baby, right? Now, other common causes of blunt trauma are falls, aggravated assaults, intentionally inflicted injuries, right? Were present in approximately 1/3 of these injuries. It can cause serious intra-abdominal injuries, and orthopedic injuries are also encountered with some regularity. So perinatal death rates are directly proportional to the severity of maternal injury. It is more likely to cause an abnormality if you have direct fetal-placental injury, if you have maternal shock, pelvic fractures, maternal head injury, or anything that causes hypoxia. MVAs account for 80% of trauma-related deaths in pregnancy, deaths which was caused by placental injury in half of that time. And uterine rupture was found in about 4%. Catastrophic events that occur with blunt trauma include placental injuries, abruption, or placental tear or fractures, and uterine rupture. Some degree of abruption complicates about 1 to 6% of minor injuries and up to 50% of major injuries. And the other thing that here I want you to pay attention to is abruption is more likely in speeds of excess of 30 miles per hour. So at 10, 20 miles per hour, the impact is much less. But once you hit the 30 miles per hour at the impact, you increase your chances of having an abruption. Blunt trauma results in uterine rupture in less than 1% of the cases. Rupture is much more likely in a previously scarred uterus, multiple, myoma removals or prior C-sections and so forth. Maternal and fetal outcomes are directly related to the severity of injury. Relatively minor injuries were associated with preterm labor and placental abruption, with few exceptions, right? When you have somebody that is involved in trauma, mom first, baby second. You've got to try and save the mom, take care of the mom's injuries. So with the few exceptions, treatment priorities in injured pregnant women are directed as they would be for the non-pregnant woman, with the goal of stabilization of maternal injuries. Always keep in mind, you can't have a baby if you don't have the mom. So you've got to make sure that you take care of mom. So if you do, ultimately the baby will be taken care of. So basic rules of resuscitation. You've always got to maintain ventilation. And if there is a source of hemorrhage, you've got to make sure that you arrest it. And if there is hemodynamic instability, hypovolemia, tachycardia, you've got to make sure that you do the measures to correct it, whether it's through fluid resuscitation, whether it is through giving blood products and so forth. But you always need the mom ventilated. And as much as you try and treat the hypovolemia, if you don't stop the source and arrest the hemorrhage, your resuscitative efforts are not going to be fruitful. So it is prudent to fix the problem before you start giving the remedies to correct it. Okay, now also keep in mind, we talked about this, the large gravid uterus is positioned in a way that can decrease cardiac output, venous return, and so forth. So that is another thing that you should take into consideration when you are resuscitating somebody, especially if they end up going into cardiac arrest. All right. Now, once feasible, evaluate for fractures, internal injuries, bleeding sites, and placental abruption. Now, one tool that is used is a CT scan, but one bedside nifty tool that can be used to see if the patient is bleeding is the FAST scan, which is the focused assessment with sonography for trauma. So it is a 5-minute and it involves 4 to 6 views that look at and evaluate the perihepatic space, the perisplenic, the pelvic, and the pericardial views. And if you see fluid in any of these views, then you anticipate that you have more than 500 mLs of bleeding, and that can dictate your management, your resuscitative efforts, and what you do in that time period. Okay, now the problem with that is this has not been validated for pregnancy at all. Okay, but you would anticipate that if you think that there is more than 500 mLs of bleeding based on your ultrasound, that would be very applicable in pregnancy. And at the other hand, it is fast, it is quick, it is at bedside, and it gives you a lot of information. Penetrating injuries in most cases must be evaluated by radiography, and then exploration is mandatory for abdominal gunshot wounds. Close observation for select stab wounds is acceptable. Diagnostic laparoscopy can also be used. The necessity for cesarean delivery of a live fetus depends on several factors. Some considerations include the gestational age, fetal condition, extent of uterine injury, and whether the large uterus hinders adequate treatment or evaluation for other intra-abdominal injuries. So keep in mind, right? If you have somebody who has cardiac arrest and you're unable to resuscitate them, you're unable to bring them back, Could emptying the uterus or evacuating the uterus be something that is helpful? Absolutely. Now, this is something that a lot of you kind of are hesitant to do. Doing a laparotomy itself is not an indication for a hysterectomy and delivery. Doing a laparotomy does not mean you have to deliver the baby. Now, sometimes they do go hand in hand. Other times they do not. So you always have to look at the fetal status, because it is considered by many as a vital sign, because it tells me the status of the mother. If the baby's fetal heart rate is decelerating and not doing well post-trauma, it could be because the mother is bleeding. It may suggest an abruption. And then remember, placental abruption can usually occur soon following trauma. And treatment should be begun as soon as possible, and putting the patient on the monitor should also be done as soon as possible if the injuries and the maternal status allows. Now, I'm going to ask you guys a question. In your hospital, what is your protocol when somebody comes in with trauma? They go to the ER clears them. They're right now in your labor floor. How long do you monitor them in your hospital, and what determines that length of hospital stay? Anybody wants to put a note in the chat box? Do you monitor them for an hour, 2, 24 hours? What dictates your decision? So the answer really is the ideal duration of post-traumatic monitoring is not precisely known. The only thing that we know is after trauma, there has to be some degree of monitoring. But the knowledge that if nothing happens in the first 4 to 24 hours, then it is seldom likely that the baby will be affected from that trauma, which then puts our monitoring times somewhere between 4 to 24 hours. There are some others that say observation for 4 hours is reasonable, as long as the fetal heart tracing and the maternal status was reassuring for these 4 hours. There are some others that dictate the length should be based on whether there is direct abdominal trauma or not. So you can observe 24 hours if there is direct abdominal trauma, and 4 hours after non-direct abdominal trauma. It really depends on your comfort level, what the maternal status is, what your hospital uses as a protocol. But I don't think that you're going to find anybody that is going to monitor somebody post-trauma for less than 4 hours. Now, you can also use other adjuncts. You can use a KB stain, right? And if you guys remember, a KB stain tells you whether fetal cells have crossed into the maternal circulation. Okay. Now, does anybody remember the mechanism of action of a KB stain? What is the mechanism of action of a KB stain? How does it work? Anybody want to remember? Anybody remembers? Anybody wants to put it in the chat box? Okay. I'm going to give you guys a hint. Fetal cells are more resistant to acid. So a KB stain is an acid elution test that utilizes that feature, meaning if you put acid and the cells go away, those are usually the maternal cells, and the ones that stay are the fetal cells. Remember also, it is affected by maternal conditions that can increase your hemoglobin F, such as sickle cell and thalassemias. Okay. One last question. If this was an Rh negative mom and you did a KB stain, can that tell you how much RhoGAM you need to give? Can that change and influence the amount of RhoGAM that you give? The answer is yes. All right. Remember, 30 mLs of fetal blood need 1 ampule. 15 mLs of fetal red blood cells require 1 ampule. So if you have, 15, all right? So if you have 20 mLs of fetal red blood cells or fetal cells, then you need 2 ampules of RhoGAM. RhoGAM, the mechanism of action, acts as a sponge. The RhoGAM tries and gets the antigens, attaches to them to evade the maternal immune system response. And at that point, if the antigens are not detected, no antibodies are formed. Now, okay, this is the trauma. So remember, for women who are D negative, we need to give RhoGAM, and you've got to assess the need for a tetanus toxoid, depending on what type of injury it is, whether there is a high likelihood of tetanus or not. And then Tdap is preferred when available. So remember, okay, similar to non-pregnant patients, pregnancy does not affect the maternal outcome in thermal injuries. Maternal and fetal survival is related to the percentage of burned surface area, meaning the more surface area that is burnt there, the more there is abnormalities. Higher mortalities rate for both with suicidal attempts and with inhalation injuries. But let's look at this. For 20, 40, and 60% burns, the maternal mortality was approximately 4, 30, and 93. So that means a 60% thermal injury has a 93% maternal mortality. That's a lot. Now, the corresponding fetal mortality rates were 20, 48, and 96. Again, you can see this linear correlation. The more thermal injury, the more the burn, the more the abnormality, the more likely the mom to die, and the more likely the baby to die. With severe burns, the woman usually enters labor spontaneously within a few days to a week and often delivers a stillborn. Contributory factors are hypovolemia, pulmonary injury, sepsis, and intensely catabolic status with these burns, right? Now, cardiopulmonary resuscitation, you've got to relieve possible venocaval compression by left lateral uterine displacement, okay? Administer 100% oxygen, establish intravenous access above the diaphragm, and assess for hypotension that warrants therapy, which is defined as systolic blood pressure of less than 100 mmHgs or 80% of baseline. You've got to review the possible causes of critical illnesses and treat conditions as early as possible. Remember, let's say if you have a patient in DKA, diabetic ketoacidosis, what do you anticipate to happen to the fetal status? It is going to become non-reassuring. The answer is not delivery. What do you have to do in somebody who is DKA? You've got to resolve the DKA before you contemplate delivery, or otherwise you have committed a malpractice. You cannot deliver somebody in DKA without fixing the DKA. All right. So in a non-pregnant patient, when you do chest compressions in the optimal fashion, the correct way, only 30% of cardiac output is achieved. That's not great. Late in pregnancy, you've got uterine compression on the great vessels. That means uterine displacement is essential. Now, the American Heart Association recommends manual uterine displacement, either using the one-hand technique or the two-hand technique, right? Rather than tilting the patient, because that actively moves the uterus out of the way. Actively moves the uterus out of the way, and this makes the compressions more effective and hopefully better access to airway management and also defibrillation if it is needed. Human wedge, you put the maternal back on the thighs of an individual who is kneeling on the floor So you use the human wedge to tilt the patient. Now, during maternal resuscitation, emergent perimortem cesarean delivery for fetal salvage and improved maternal resuscitation may be considered. The usually agreed upon time is 4 to 5 minutes after the cardiac arrest. Arrangements or at least planning should be made to go ahead and evacuate the uterus if the mom's circulation does not return. Now look at this. Newborns delivered within 5 minutes of a cardiac arrest have a 98% chance of being neurologically intact. Logically, the longer that you wait, your neurological status starts to go downwards. So at 15 minutes, 83% will be intact. At 25 minutes, 33%. If you head to the 35-minute mark, you are really looking at a point where a lot of these babies are going to be neurologically damaged. So the American College of Obstetricians and Gynecologists recommends consideration for cesarean delivery within 4 minutes of cardiac arrest. Unfortunately, this may not always be feasible, because if you look at a code in a hospital, by the time people come, by the time that people are around the code, and especially if it was a code that was not anticipated in a pregnant patient, to have the availability, the tools around to do a perimortem cesarean delivery is not always easy. Now, also keep in mind, keep in mind that when you do a perimortem cesarean delivery, the bleeding is much less at that point because there's no heart pumping. And then after the circulation is retained, you may actually have bleeders that were not otherwise noted or seen or something like that. So keep that in mind when you do a perimortem cesarean. All right. The conventional teaching is that resuscitative hysterotomy should be undertaken after 4 to 5 minutes of arrest without the return of spontaneous circulations. Obstetricians should be aware that there is no obvious threshold for death or damage at 4 to 5 minutes. There is progressive decrease in the likelihood of injury-free survival for women and fetuses with lengthening time since the cardiac arrest. Survival curves for women neonates have shown 50% injury-free survival rates with a perimortem cesarean delivery. Okay, even if delivery does not occur within 4 to 5 minutes, there still may be benefit, and resuscitative hysterotomy should be considered. However, a more rapid resuscitative hysterotomy has been associated with improved survival, and the procedure should be considered as soon as feasibly possible. Now, for patients that have brain death that are pregnant, under certain circumstances, a pregnant woman can be kept on the ventilator for somatic support in delivery to allow the baby further maturation and less need to go to the NICU. Admission to the ICU is dependent on what your labor and delivery can offer, what your antepartum floor can offer, with certain labor and deliveries having more capabilities than others, such as the ability to have one-to-one nurses, telemetry, all that sort of stuff. So admission is dependent on the levels of care available on your local level. Critical care in pregnancy relies predominantly on recommendations from the non-pregnant population with only limited research. However, there are indications post-delivery because somebody has a cardiac abnormality, post-cesarean hysterectomy, or in somebody who we are struggling with their hypertensive management, somebody who is septic. These are all reasons for somebody to go to the ICU, needing pressors and is unable to maintain their blood pressures, or requiring ventilation. So respiratory support, including airway maintenance and endotracheal intubation, is usually an indicator that you need to go to the ICU. Pneumothorax, if you need pressors, pulmonary artery catheterizations, and invasive monitors. Now, if you have abnormal electrocardiographic findings requiring intervention, defibrillation, including cardioversion, and so forth. All right, with that, we conclude today's 4 lectures.